We are live from the studios of the Association of African Universities headquarters here in Accra, Ghana, and this is AAU Talks. My name is Kwesi Sam, and today on AAU Talks, we are looking at the SDG Goal 3.3, which talks about the fact that we need to end HIV and AIDS as a public health threat by 2030. Is this vision possible? Do we think we can get there? Do we think we can actually end HIV/AIDS by 2030? And to help us with a discussion, we have a Ford Foundation alumnus in the studio, and he is going to share his thoughts and his views on whether or not HIV and AIDS can be ended as a public threat by 2030. This is AAU Talks. You can join us via our social media platforms, Association of African Universities on Facebook, and AAU_67 on Twitter. I'll go for a short break, and when I return, I will let you know my guest. Stay tuned. Welcome back from the break. This is AAU Talks. And before we left for the break, I told you what we'll be discussing today. We are looking at SDG Goal 3.3, and we are looking at how we can end HIV/AIDS as a global or as a public threat by 2030. And we are privileged to have Mr. Isaac Offei, who is a Ford Foundation alumnus, in the studio to help us with the discussion. Sir, you are welcome to AAU Talks.
Thank you.
And how are you doing?
Very well, thank you.
Great. We are so much privileged to have you back after so many years. And where have you been?
I used to work in Nigeria on HIV, and then I moved to Liberia, covering Liberia and Sierra Leone. And currently I'm in Malawi, working as a fast-track advisor with UNAIDS.
That is after the Ford Foundation?
After the Ford Foundation. Actually, I completed Tulane University with support from Ford in 2008. I had a master's in public health with a focus on health system strengthening.
That's good.
So when I came back, I worked as a senior health advisor for SNV, which is the Netherlands Development Organization. And basically what I was doing then was to support the National Health Insurance Scheme and also support the two regions that I was working in, Central and Western region, basically focusing on maternal child health and the National Health Insurance. Then I moved in 2009, late 2009, back to UNAIDS in Nigeria, where I started my work again on HIV and AIDS.
So why did you choose that path, HIV and AIDS?
It's a very long story. I did my bachelor's in social work practice, and as part of the course, you are required to take field studies. And in 1996, I was sent to the Holy Family Hospital. At the time, there was no treatment for HIV. So basically, we had a group of people living with HIV that we were supporting directly, providing support in terms of income-generating activities. But we were also sending them to Akwetia Catholic Hospital, I think it's called St. Joseph, where they were given immune boosters by a Catholic priest because there was virtually no treatment at the time. And that is what kept them moving. But since then, I continued to work on HIV issues since I finished school. From the Catholic hospital at Nkoko, I moved to Catholic Relief Services,
Okay.
still as a program officer in charge of HIV/AIDS. And then I joined VSO later down the line. And then eventually I went to UNAIDS, where I worked as a national program officer before leaving for my academic work in 2006.
All right. Let me congratulate you for the good work
Thank
that
you.
you've already done and you are yet to do.
Yeah.
But today on AAU Talks, we are looking at the SDG goal 3.3, which scares some of us because it is a bigger vision. Let me put it that way. How we can end HIV and AIDS as a public threat by 2030. To some of us, it looks scary. It's not possible. But you are an expert. What do you think?
I think ending HIV as a public health threat is achievable. People tend to misinterpret when you say ending HIV as a public health threat. They think you are saying eliminating HIV as a public health threat, but that's not what we are saying. What we are saying is by 2030, all countries should have achieved what we call epidemic control. If a country achieves epidemic control, what will happen is you will have less new infections than AIDS-related deaths. So the number of people dying of HIV-related causes will be much more than the new HIV infections that you have in the country. Once you get to that level, then we can say the country has actually reached the level where they can keep the epidemic in control. So that's what we are looking at. And we do believe that currently we have all the technology, the skills, and if we would take the appropriate measures, HIV as a public health threat should be ended by 2030. Currently there is so much going on. Working with other agencies and other countries, there has been a decision that all countries should work towards achieving what we are calling the fast-track targets by 2020. What the fast-track targets seeks to achieve is that by the end of 2020, all countries should have been able to identify 90% of people living with HIV in the country. And once you have been able to identify 90% of the people living with HIV in the country, you put at least 90% of those you've identified on HIV treatment, antiretroviral treatment. And we do believe that if you put 90% of the people living with HIV on treatment, by the end of 2020, 90% of them should have achieved viral suppression. And if you achieve viral suppression, then it means you are no longer infectious. You cannot transmit the HIV virus to other people. And in so doing, you would have prolonged your life by being on treatment, but also you would have prevented the infection from spreading to other people. So most countries have working towards reaching these targets. And I think by 2020, we should see a significant improvement in the global pandemic.
It sounds great, but you made mention of the fact that we need to make sure 90% of every country's population, or people living with HIV
know their status.
But how is it easy for us, especially in a region where stigma is one of the key things that prevent people from knowing their status?
That's very true. I think if you look at the figures, of the 390s, that is the greatest challenge. Because most people are not testing because of issues related to stigma, discrimination, and issues like that. We as a people need to address that. Currently, we have introduced what we calling self-testing kits. So people should be able to assess these test kits and do their own screening by themselves. And then you once you know your status, whether it's positive or negative, at least that gives you a bit of comfort to be able to go to a health facility for a confirmatory test. If you are positive and you see by yourself that you are positive, then you can go to the facility. The additional test will be done, and then when you are positive, you are put on treatment. Again, you realize that for most of our mothers in most places, particularly in the Southern Africa region, most women who are pregnant are tested for HIV. So we are able to capture many more women than men. Now, the challenge has been, how do we get men particularly to go for HIV testing? And I strongly believe that our services are not designed to reach out to men. And perhaps that is an area we need to improve. Men do not come to hospitals. So if you put the HIV testing in hospitals, they are not going, you are not going to reach them.
So we need to go to the stadiums.
We need to go to the stadiums where football is being played, go to the drinking bars, make sure people have access to testing services. And more importantly, most men are also working in businesses. You go to Abosokai or any other place where you find a lot of men. We could take the services to them rather than asking them to come to us for services. I think once we do that, most likely we are going to get many more people to get tested. But we also need to work on the stigma. Stigma is a factor. Is a factor of the fact that most people have limited knowledge on HIV and AIDS. Sure. People think when I eat with you, I could get infected. When I sit with you, I could get infected. I think we need to demystify the way people perceive HIV to be. I remember those days, they would tell you, okay, if you touch somebody, mosquitoes will spread it. If you look at even our demographic health survey, particularly for Ghana and most places, there are 5 questions that is asked about HIV. And you realize that we haven't still hit 50%. Most of the countries are recording less than 50% in terms of the knowledge on HIV and AIDS. So we need to beef up the knowledge for people on HIV AIDS. But particularly with students, I strongly think that our life skills and it is called differently in most different countries. But we need to do more with comprehensive sexuality education and reproductive health in school, so that people build knowledge. And if it is even possible to make it examinable, then people will take it serious, and then they see the relevance of having HIV test. I think people don't understand why they should have a test. Because if I'm healthy, why should I have an HIV test? Because it is not going to add value to my life. Okay,
but let me come in. You know, people also have this kind of misconception that if I get to know my status, it rather affects me psychologically, emotionally. I get depressed and perhaps maybe even die faster than not knowing. And that is African mindset. Is it relevant to the entire process?
I think it's a valid point, because most people think about the stigma rather than the benefits of knowing your status. But the good thing is, once you know your status, then it makes it possible for you to assess treatment and to avoid the situation where you start developing the opportunistic infection and dying much quicker than expected. And people also need to realize that once you know your HIV status, it is protective, not just to you, but also to your partner. And also it allows you to do your work without getting into the level where you become sick and then you need massive treatment before you can recover. So I think we need to tell people a bit more also about the benefit of knowing your status and the fact that once you know your status, there is free treatment in almost all countries. HIV treatment is free. So people should not think that once I'm going to spend so much money knowing my status and the drugs are not available. No, these drugs are available for free in almost every country. And once you know your status, you should be able to access the treatment.
Yeah, they're in abundance, because we hear stories where people go to the hospitals and they are being told there's a shortage, and so they have to go back home.
One of the things that we have been able to do as a global response is that in 2002, when Kofi Annan was the Secretary General, one of the things that they pushed for under the MDGs was the establishment of what we call the Global Fund for HIV, TB, and malaria. Now, what the Global Fund has been able to do is that they are investing almost $4 billion every year into HIV and the 3 diseases. But a lot of it, about 70 to 80% of the investment is into HIV. And about 70% of the HIV investment is also on just drugs.
Okay.
So most of the countries, particularly in sub-Saharan Africa, get their HIV drugs for free, with the exception of a few countries like Botswana, where government is putting in money to pay for drugs themselves. Almost all the countries get HIV treatment drugs virtually for free. And increasingly, the drugs are getting cheaper and better.
Okay.
So you have, in the past, you spend about $500 per annum on antiretroviral drugs.
Okay.
Now you spend less than $100 because of the negotiations that have gone on with the drug producing companies. So you are getting the cost very low, so the drugs are easily accessible. But more importantly, like I said, the drugs are getting better.
Okay.
Recently, we realized that there is a drug that we are calling simply as the DTG. Once somebody is on DTG, within a month or two, his viral load decreases significantly.
Amazing.
It decreases to undetectable levels. And because of that, then they cannot transmit. But recently, we've also heard that there are problems with the drugs, particularly for pregnant women, because there are birth defects for pregnant women who are on DTG. But when it's men and people who are not into reproduction, particularly for women, then you are fine. You take the drugs within 3 months, your viral load reduces significantly, and it's not detectable anymore.
All right. We'll go for a short break, and when we return, we'll look at the statistics globally and then what we have on the African continent as well. Viewers, this is AAU Talks, and we have been speaking to Mr. Isaac Offei, who is sharing much more knowledge on how to really end HIV/AIDS or reduce HIV/AIDS by 2030. Stay tuned. We'll go for a short break.
One of the universities set up in our pre-independence era, the Kwame Nkrumah University of Science and Technology. Our international reputation has and continues to soar as a reference point in matters of science and technology, research and education. We believe that the future belongs to those who have sound technology acumen.
I love USD.
I love KNUST.
Welcome back from the break, and we are still discussing SDG Goal 3.3, and that is ending HIV and AIDS as a public threat by 2030. And we have Mr. Isaac Offei, who is discussing or helping us understand the issues and how we can achieve this goal. So, Mr. Offei, before we left for the break, we're about looking at the statistics globally, and then we zoom into Africa. How many people are living with HIV/AIDS globally? And then in Africa, how many people are also living with HIV/AIDS?
As of 2016, we had about 37 million people living with HIV globally.
Out of the 7 billion.
Out of the 7 billion people. And as you think about it, because now people are on life-saving drugs, so many more people are living with longer with HIV. So we expect that the numbers will continue to grow as we put many more people on treatment. But if you look at the number of people who are infected with HIV, over 70% of them are in sub-Saharan Africa, which is a major problem.
70% of the 37 million.
Approximately 25 million people, over 25 million people out of the 37 million are within sub-Saharan Africa. And that excludes North Africa, but you're looking at West and Central Africa and East and Southern Africa regions. That is where the bulk of people living with HIV, where they can be found.
That's a bit serious.
It
Out
is.
of 34,
37.
25 million. Just sub-Saharan
Africa. And if you look at the number of new infections we had in 2016, we had 1.8 million people newly infected with HIV in 2016 alone. Of this number, about 1.3 of them are still within the same region of sub-Saharan Africa. 1.3 out of 1.8 million people were newly infected in sub-Saharan Africa alone. If you look at the number of people who died of HIV-related causes in 2016, there were 1 million people in total for the entire world. But over 730 of them are still from the sub-Saharan Africa region. West Africa, Central Africa, East Africa, and Southern Africa. So we are the highest burden of the HIV epidemic in the world.
So why is it that the North Africans are a bit they have a lower prevalent rate?
I think if you look at the transmission dynamics of HIV across the globe, you realize that in sub-Saharan Africa, much of the transmission is through sexual transmission. If you look at Eastern Europe and most part of Europe itself, you realize that most of the people who are getting infected are through people who inject drugs. So much of their infections are coming from people who inject drugs. If you look at the other ways of transmission, like blood transmission, is very low. We in the sub-region are also not doing very well when it comes to transmission from mother to child. So we are getting many more children below age 5 infected, or up to age 14 infected from mothers
to child
in the sub-region than any other place. Countries like Thailand, countries like Cuba have achieved elimination. So virtual elimination of mother to child transmission doesn't happen anymore in a place like Cuba. And I strongly believe that in countries such as Ghana and many other parts of Africa, we have the capacity to prevent mother to child transmission, which is easy to do if we can just put the pregnant women, get them tested, put them on treatment, and ensure that whilst they are delivering, they've been given the drugs that they need. And also when they are breastfeeding, if they are breastfeeding, they do exclusive breastfeeding. And when they are taking the kids off breast, they do it at the time when the health officials have told them to do so. And also make sure mothers who are infected are on life-saving drugs, because once they reduce their own viral load, then the possibility of transmitting to their babies is lessened. So it is something that we can actually achieve.
But I think in Ghana, it is done. Most of the women who go for antenatals, technically they do the testing. Maybe those who do not visit the health facilities for the antenatal procedures or whatever are the ones who are affected. I don't know for other countries though, but in Ghana, I'm sure that is done because the reports really indicate so.
Yes, the people who go to the facilities are getting tested, but what is the follow-up to ensure that they deliver within facilities? What are we doing to ensure that these mothers who have been identified as women living with HIV are given the life-saving drugs so that they don't deliver babies with HIV? It's for me as a Ghanaian, I feel it's a bit worried because we have the CHIP system. The CHIPS is supposed to ensure that medical services are as closest to the people as possible. So a woman who is pregnant, who has been to the facility, who has been tested to show that he is positive, there is no reason why we should lose him in the process and then they get infected. Unfortunately, Ghana has the highest burden of mother to child or under 14 children living with HIV in the sub-region. within the West Africa sub-region. It is the highest because I think we are not doing too well by putting a lot of the women who are already known to be HIV on treatment. And we are not following up enough to ensure that they don't transmit. Because the seroconvergence doesn't end with delivery.
Okay.
But what do you do with breastfeeding? What do you continue to ensure that, because we also need to monitor, we must be testing the infants at 6 months, at 12 months, and at 24 months to ensure that they are not seroconverting. And if they are converting, then we put the babies also on treatment. But we are not doing that too well. Because I've left Ghana for a while, I'm not too sure what the issues are. But I think we could do much more by ensuring that many more children are prevented from getting HIV from their mothers.
Okay. So let's look at the statistics in terms of the regions in Africa. Let's exclude the north because we definitely know that it is not too high. But looking at western and then central, eastern and southern, how is it like?
You know, we put West and Central Africa together as a block, and then we put Eastern and Southern Africa as a block.
Okay.
If you look at in terms of numbers, Eastern Southern Africa has many more cases. Okay. If you recall, right from the 80s when HIV started, many more people died in that region. For countries like Botswana, Swaziland, they had HIV prevalence close to 30% of the population. Now they have accelerated the prevention activities, and now it has reached very manageable numbers. As low as a country like Uganda, which used to have HIV prevalence of over 20%, is now about 6%. Okay. Now, for a country like Ghana, and in most West African countries,
within the 1 point.
It's 1.2, 1.8, 2.3. We've always been within the 1.5 to 2.2. And yet, if you look at specifically the number of new infections going up, as a proportion of what the reductions we are seeing in the Southern Africa region, it is far significant. We are seeing more reductions in the Eastern Southern Africa region than in the West and Central Africa region. What is even worse is we are putting less number of people on treatment in West and Central Africa region compared to Eastern Southern Africa.
Is it not because of, again, the stigma? Because I know in Southern Africa, it is so easy for someone to declare his or her HIV status. But even in Ghana, you know this person has it, but the person will boldly tell you as a medical practitioner, I don't. And it also comes back to the fact that we feel the stigma here much more than there.
Stigma is equally high. Of course, it's much higher in the West and Central Africa region compared to the South, because they saw many more HIV-related deaths, and almost every family was affected. So they have a better perception as to how to relate to a person living with HIV than we do in West Africa. But having said that, I think there is much more that we need to do than just claiming that is just stigma and discrimination. I think we haven't pushed enough to get people on treatment. Because, for instance, you take a country like Ghana, you have less than 300,000 people who are living with HIV out of 27 million. Now, if we provide services, we should be able to at least reach, let's say 50%. Get about 50% to know their status and put them on treatment. That is not what is happening in West and Central Africa. If you take, I can just do a comparison of the two regions, as you said. I talked about the 1990.
Yes.
Getting 90% of the people living with HIV to know their status. If you look at East and Southern Africa region, 76% of the people living with HIV know their status.
Okay.
Compared to West and Central Africa, it's only 42%. If you look at the number of people who know their status, who have been put on treatment, for East and Southern Africa, 60% who know their status are on treatment. If you come to West and Central Africa, it's less than 30%. And as a result of that, most of the people who know their status and are receiving treatment, over 50% of them have reached viral suppression.
Okay.
In in West and Central Africa, it's less than 25%. So we are not getting that right. We are not getting people to know their status.
Okay.
And we are not doing enough to put them on treatment. Of course, it's difficult to find 300,000 people among 27 million people. It's much difficult than like in Malawi, where you have 1 million people infected with HIV or living with HIV out of 17 million. So you are likely to find them. But the point to notice, if you take Malawi, which has 1 million people, almost 70% of the people living with HIV are currently on treatment.
Okay.
You take the case of Ghana, it's less than 50%. We are still at 45%. So I think we could do more.
Why are they not on treatment if the services are there?
It's a question that all of us need to help the health system to address.
Okay.
Because like I always say that the way we have built our health systems, if you go to a facility, there is maternal and child health clinic here. You have people coming for STI clinic in another place. You have people coming for non-communicable diseases in other places. The family planning services are somewhere. HIV services are scattered. We haven't been able to integrate our services such that when a person enters into a health facility, he should get a package of services. That includes HIV, that includes family planning. I may come for malaria, but it would be good for a health worker to talk to me about family planning. It would be good to talk about condoms. So then as I'm going, or sexual reproductive health in general, so that as I'm going home, at least I have additional information that helps me to prevent HIV or STI or on an unwanted pregnancy.
Okay.
But the way our health facilities are structured doesn't easily allow that. And again, like we said earlier on, men do not come to facilities. The way the health system is does not encourage men to say, okay, I'm coming to a facility where there are too many women, fewer men. I'll tell you a funny story. There was a study that was done in Malawi, where men are encouraged to come with their wives to antenatal clinics. So they come. But when they get to the hospital, they don't go into the facility because they come with their bicycles and they have to park the bicycle elsewhere. And they need to keep an eye on it before somebody steals the bicycle. So you don't expect the man to leave the bicycle and go and sit there and listen to the health education that is given. So even though they are coming to the facility, they are not benefiting from the health education. So those are the very little things that we can do to improve on access to HIV and AIDS services within facilities.
Okay, we'll go for a quick break, and when we come back, we'll also look at another interesting aspect of prevention of HIV-related cases as well. But even before we go for the break, I think let's look at this before we go for the break.
Okay.
We're looking at an issue of which of the known causes, which of them is so prime, because we talk about the sex one as the most way of, or the known or the popular way of someone contracting HIV/AIDS, vis-a-vis the mother to child, and then the other means. Which of them do you think is key?
I strongly think that in our region, because it would differ in many places. In the sub-Saharan Africa, where you're looking at sex as the main driver, it is imperative that we deal with it. But it's not just the issue of sex, but what are the root causes of unprotected sex in our system. If you look at HIV prevalence across the globe, young girls between the ages of 15 and 24 are 2 to 3 times at a higher risk of HIV infection than boys or young men in the same age. Why is it so? Because one, most of the girls start having sex at a much early age. The sexual age of sexual debut is higher for girls than for boys. Who are they having sex with? They are having sex with people in the 30s who are men or sugar daddies, as we call it in the Southern Africa region. We call them blessers. These blessers have money and they have multiple concurrent partners. So once they get infected, then they make particularly the young girls also vulnerable to HIV infection. There are cultural practices that goes on. In the Southern Africa region, there are initiation rites that young girls who have gone through puberty have to go through. Now, I'm sure maybe you heard this BBC story about a guy called Haniva. Haniva had slept with 120 women and girls, even though he knew he was HIV positive. And he was cleansing them, and it's part of the cleansing process. Can you imagine an HIV positive person sleeping with 120 people? Possibly most of them could be infected. As a result of that cultural practices, that continues. We've seen that child marriage is still a problem. So you look at the adolescent girls and young women alone. There are so many issues that we need to address to ensure that the adolescent young girls and young women, one, stays in school and they are able to continue with their education, and we can empower them as young people to live an AIDS-free life as they grow into adulthood. All
right. So in summary, what are the blocks? What do you think must be done to ensure that by 2030 we have a continent, or we have as globally HIV/AIDS is really reduced? I don't know, in point. What would you suggest?
Is to, one, we have our condoms. Condoms have been proven to reduce HIV transmission in sex by 90%, 99% if it is used correctly and consistently.
But it appears people don't like the condom.
So that is the risk and the choices people have to make. And it's about educating people to realize that, look, there are several varieties of condoms. They do the same thing. The important thing is the protection. People will go for a flavored condom. People will go for different reasons. But there are varieties. So depending on what you want, you will still find it. Providing lubricants to go with condom is critical that we do that. We also do know that for the Southern Africa region, we have what we call the voluntary medical male circumcision. In a region where circumcision is not part of the culture, we do know that if you can get people circumcised, it reduces the possibility of transmission by 60%. And it also, for the guy, once you are circumcised, it reduces the possibility of transmitting cervical cancer to the woman. So doing voluntary medical male circumcision is also critical. Again, we need to look at what we are calling the pre-exposure prophylaxis. These are drugs that you can take
just
before you go and have sex. So you take it for like 6-7 days to prepare the body. Then if you engage in a high-risk sex, you will still not be infected. And then you must continue with it. This is a new concept. It is coming up strongly now. In most countries, it's being introduced.
But it is limited to only the health professionals?
No. Pre-exposure prophylaxis is available for people who are at high risk. So if you among a particular group, you have HIV prevalence of more than incidence of about more than 1%, then it can be introduced. So for a group like sex workers, a group like men who have sex with men, those are high risk groups, and you would want them to. So if you have a sex worker every day she is getting exposed. It is better for her to take drugs to prevent any infection that she might come into contact with. And the other way around is when you are already been exposed and you need to take antiretroviral drugs to prevent transmission. The post-exposure prophylaxis is also available for people to take. But before we go, I think there is an issue that we need to address relating to the stigma and discrimination.
Yes.
I know in Ghana and in most parts of Africa, the issues relating to human rights and HIV prevention among the population we call key populations has been controversial.
Very, very.
Men who have sex with men, female sex workers. We even now have male sex workers. We do know that in prisons, there is sex going on in prisons. If you put this group together, we know they are a group that engages in anal sex. Now, as a result of the fact that the legal environment in which we operate does not allow them to come up openly to access services, they are not accessing condoms, they are not accessing lubricants. And so the transmission is increasing amongst them. And I think if you look at the legal framework, the Commonwealth law, which has been applied in all the countries, it's about having carnal knowledge, which is against the order of nature. If you come to think about it, what it means is any form of sex apart from vaginal sex is unacceptable, and the state has to prosecute you. So whether you are having anal sex, whether you are having oral sex, it's unacceptable, and it has to be, you have to be prosecuted. From the perspective of HIV, and having worked with that community for a while, you talk to them, the issue is not about marriage. They themselves as a community are not interested in marriage. But we, from the public health perspective, is to ask the question consistently, how do we reduce HIV infection among these populations? For countries like Namibia and Lesotho, the ministers for health came up with an idea that we have these sodomy laws in our books. We are not going to be able to change it, but we are going to go ahead and provide condoms in prisons. Because we know sex is taking place, whether through consent or is forced sex, but make the condoms available so that they are not infected. And it will be interesting for countries to do a longitudinal study of people coming into the prison, test them for their HIV status, and at the time they are leaving, check and see the seroconversions that happens in prison. We've started doing that in Malawi, and the cases we are finding is quite interesting. And I do believe that in all countries, as we discuss the issue about sodomy and the law, we need to begin to think about, from the public health perspective, what do we actually want? The dialogue is good, whether it's from the religious leaders or the education officers and stuff like that. It's all well and good. But we need to come to the point where we ask ourselves, how do we ensure the public health and safety of these people? We don't want a situation where, as a bridging population, you have a bisexual who is sleeping with a man and women, and then he has a wife because he wants to cover, so that society doesn't realize that he is a gay person. So he comes and he marries, and he's engaging with this community. He gets infected and then takes it to the wife. That is what you want to do in terms of public health, is to cut the transmission. I think
the legal aspect will be very much interesting, that we need to have a full session on, because it's really controversial. Especially with our laws, customs, and then our values and everything. But because of our time, I want to ask, do you think that a time will come, not too long, but in short term, would there be vaccination for HIV? Yes,
I think not too long ago, I think this last week, Thursday or Friday, there was a BBC report. A group of scientists in Harvard have come up with a vaccine which they think potentially could be the vaccine for the future.
Okay.
I do believe within the next 2-3 years, we would see much more positive results from those vaccine trials that are going on. I think after 2020, I strongly believe the focus of the global AIDS response will move to vaccine development.
Okay.
We may not have a cure, but it's very possible we would have a vaccine that can be used to prevent new infections. It is quite clear that all the work that has been done and we continue to build on is pushing us towards getting a vaccine for HIV. And I do believe the International AIDS Conference that is going to happen this month in Amsterdam, there will be interesting presentations on what has happened with the various vaccines that are currently on track.
Okay. That would be a good news for all
everybody.
Humanity. All right, thank you so much for coming,
Most
and
welcome.
we appreciate the time
Most
and
welcome.
the knowledge that you've shared with us. I know you still have a lot more to pour out to the entire continent. We appreciate your time so much.
Anytime.
Viewers, this has been AAU Talks, and we have been talking to Mr. Isaac Offei, who is Ford Foundation alumnus, and then also works, who has worked extensively with HIV and AIDS-related issues. My name is Kwesi Sam, and my final words to you is that I think that sex education must go down and down and down. HIV is not a curse. Know your status and live right. Stay tuned and see you next time.